Hello, and this is Khaled from OSCE Pass, welcoming you to a whole set of new videos in 2017. We have big, tremendous things due to happen this year, and I'm beginning to sound like Donald Trump at the moment, so I'm going to stop. Let's get straight into it. Right, GI examination, and Halal's going through the motions here. He's introducing himself, he's explaining to the patient exactly what's going to happen, he's getting consent, he's offering a chaperone, boom, he's a model student. One thing you could add in your examination to gain brownie points is to tell the patient that some of the parts of the examination where you palpate their tummy can be a little bit uncomfortable if they've not emptied their bladder already, and offer for them to go to the toilet first if they require it. They'll say no, you'll gain brownie points, nobody will piss their pants on top of the examination couch, and there you go, job done. It could be tempting to just jump straight into your examination and quickly show the examiner what you know, but take a moment, breathe, go to the end of the bed, have a look at the patient. I mean, don't take too long, but give it a good 10 seconds. You're looking at the patient, you're looking for signs of cachexia, you're looking for signs of jaundice, you're looking at how they're breathing. Are they breathing really quickly? Really slowly? You're looking for adjuncts. Have they got oxygen supplies, IV lines, infusions, anything else around them that would give you a clue as to what you're actually dealing with? You're essentially a detective, and you've got to do your detective work. As with most examinations, start with the hands. You're looking at the colour of the hands, bronze skin, think hemochromatosis, yellow, jaundice, liver disease. If you see tarring, you're thinking this guy's or lady is a smoker and he's been smoking for a while. Once you get onto the nails, you're looking at clubbing, and top 3 reasons to have clubbing in a GI exam. You'd be thinking about the inflammatory bowel conditions like ulcerative colitis and Crohn's disease. You'd be thinking about primary biliary cirrhosis or liver cirrhosis. So just remember those main 3 categories and you'll be all right. Colonychia looks like this. That's a sign of iron deficiency, so if you see that, boom. And leukonychia looks like this, and that is sometimes associated with hypoalbuminemia. Try saying that after a few drinks on a night out, essentially just meaning low albumin, and that could be as a result of chronic liver disease. Moving on from here, you're going to check the patient's pulse and respiratory rate, really important part of your examination, and you can do it for 15 seconds, multiplied by 4, or you can take a bit longer if you like, if you need that bit of a breather. After this, we actually forgot to do this part, but it's a really important one in the GI examination, and that is to check for a liver flap or asterixis. Now, to get this patient to do this, you ask them to straighten their arms and just hold their arms out in front of themselves, cock their wrists back, and if you see a tremor or a flap, then that could be possible signs of encephalopathy. Now, we've put some links here to show you what that might look like. Please do have a look at those. Moving swiftly up from there, you're going to the head. So you're starting with the eyes, and then again, you're looking for signs of anemia. Do they look pale? Do they look yellow, jaundice? Or are there these mythical Kaiser Flashinger rings? You know what I'm talking about. These are the rings that come up in exams and you know exactly what disease it is, but nobody's actually ever seen them.
Well done! Well done!
So Wilson's disease, these kind of rings appear around the iris. Moving down to the mouth, you're looking for signs of poor dentition or gingivitis, which is essentially gums that are inflamed and diseased. Now, one of the reasons for this could be a condition called scurvy. Now, I don't know exactly why I said as a pirate, but if you remember a few things, you might actually remember about this condition. Pirates are out at sea. They have very little vitamin C because they've left their fruit and veg with their missus and their loot room or whatever. And you get bleeding gums and dirty teeth with scurvy. Continue your investigation into the mouth. You're looking for things like aphthous ulcers, so ulcers that could be caused by Crohn's or ulcerative colitis. More likely Crohn's, though. You're looking for glossitis, which essentially means a large tongue, which can be found in patients that have iron deficiency anemia. Or if patients have angular cheilitis, which is essentially small cuts to the lip, again indicating iron deficiency anemia. You're moving down to the neck, and at this point you're looking for a raised JVP. If it's massively raised and they have engorged veins and edema, you're thinking more like an SVC obstruction. Also, you could be thinking about things like a hepatovenous obstruction type picture. Then move on to palpate the neck for any signs of lymphadenopathy. One node to always remember about is called Virchow's node, and it could occasionally be a sign of GI malignancy. It is located in the left supraclavicular region, so if you feel this node, be very, very suspicious. Moving on to the main part of your examination, you're actually now at the abdomen. So best to reposition the patient at a level where they are lying supine on the bed. Get them to expose their abdomen. And at this point, you are inspecting for any of the skin changes that we've already mentioned numerous times. You're also looking for any changes in the shape of their abdomen. So is their abdomen distended? Don't forget the 6 F's for when it comes to lumps or bumps in the tummy. You're thinking about, could it be fat? Could it be fluid? Could it be flatus? So wind. Could it be feces? Disgusting, I know, but it does happen. Could it be a fetus? In this case, probably not, but you never know. Or could it be a flippin' big tumour? Yeah, fair enough. And again, you're trying to assess everything by just looking to start off with, so do it next to the patient, but also bring yourself down to the level of the abdomen. You get a far better view when you're actually down by the abdomen and looking across the abdomen. And again, you're looking for signs of scars and stomas and whatnot. Beauty of actually making OSCE videos and trying to teach people is that actually most of the time you learn new things yourself. One of the things that we never got taught in medical school was to actually do auscultation next. So you inspect and then you auscultate the abdomen. The main reason is that any palpation that you do actually perform could alter the bowel sounds, could alter the pathology of the abdomen, and could give you inaccurate results, which theoretically, yeah, it does make sense, you know. So why not do it? So auscultation, you're listening for bowel sounds, whether they're active and the bowel is actually working, whether the pitch of the bowel sounds is very high-pitched or tinkling, as some people would call it, and this could be an indication of a small bowel obstruction. And you're also listening to the aortic and renal regions for breweries. Okay, now you're on to the palpation, and just before you rush and start doing your palpation, ask the patient where they have their pain. A really good tip is just to start away from the region of the pain and see the patient how they are with that. It gives you an idea of how much pain they are in, but also look at their face as you're palpating. Start off with just light palpation in all of the different regions of the abdomen. Move on to slightly deeper palpation, and again checking the patient's face to make sure that they're not in excruciating pain. Once you've done this, you are now ready to examine for the patient's liver. So you're trying to check if they've got any hepatomegaly, get them to breathe in and breathe out as you do this, and then you can also do percussion to give you another bit of information about where the liver is. Move across from the right side to the left side to do the same for the spleen, and again don't forget to percuss. Once you've done this, you're now going on to the loin area to check for the kidneys and any renal angle tenderness that might be there with things like pyelonephritis, and move on to check for an abdominal aorta by palpating the abdomen centrally for this expansile mass, which could possibly indicate an aneurysm if it's particularly large. Lala's now demonstrating how to check for shifting dullness, and this is a way to check whether the patient has ascites. If the dullness is moving as you move the patient with gravity, you're thinking that there is some fluid in the abdominal cavity. And there you go, you've completed a slick examination of the abdomen. You've got some knowledge of a few conditions that you could look out for. It's really important that in your closing summary to the examiner, you don't rattle off all the negatives. You say things like, there are no stigmata of chronic liver disease in this patient. If there isn't, don't just remember that and say it when you've actually found spider nevi and various other things. So make sure you tell the patient and the examiner the important positive findings, and if there are no negatives, you just say a random statement like the one I've just said to cover it. And if the examiner wants to ask you more questions, they bloody will, and just be ready for that eventuality. Thank you for watching, and I hope to do a lot more of these videos. Actually, 2017 is looking a bit better in terms of time-wise for me to focus on these videos for you, so give me a shout as to what you would like to see next and what you would like OSCE Pass to help you with. I know we've got lots of different students. We've got nursing students, midwives on here, physiotherapists. If there is a specific type of examination you want to see, drop me a shout and leave your comments below and share with everybody. Peace out.